right, well, thank you to the HDSA for picking Spokane, first of all, as a meeting place. That way I could roll down here from just a couple miles away at my house, and happy to give this presentation. I've had an interest for a while in access to care, and we've worked with telemedicine research, first for Parkinson's disease, with the Connect PD study, which is something that Dr. Ray Dorsey, who's actually involved with Huntington's work as well, developed to kind of basically show that telemedicine was no worse than routine clinical care, and patients actually rated it higher in terms of their satisfaction and access to care. And so being here in Eastern Washington, I've been here in Spokane, Washington for about just over 10 years now. We have an urban area. This is a city of 250,000, about 500,000 in the county and 600,000 in the metro, but we serve in our area about 2.5 million. And so, we're often challenged in trying to connect with patients far outside of our area as well. So we kind of have a regional and rural model. And I think really every HD center struggles with this, even in probably very large areas, have patients coming very far away. But for us, it's a little bit more of an impetus to try to address and recognize the challenges with this and come up with solutions. So this is kind of why I advocated for and decided to, I guess was nominated in that sense, to present on this topic today, Bridging Rural Regional Healthcare Divide for Huntington's Disease. So again, I'm a board-certified neurologist based here in Spokane. I own my own practice, Selkirk Neurology. So we're a private practice that functions kind of as a tertiary care model system with a large referral network. And also own a research company called Inland Northwest Research. We run a lot of clinical trials, many of which are for HD as well. So we'll get right into the mix of it here. We're going to have a few clicker troubles today, but I'll just have you go ahead and advance it, please. Again, the disclaimer for HDSA. Okay, next. Okay, no disclosures on this topic. So here, you can go ahead and hit next. These are the Selkirk Mountains. If any of you thought that I was Dr. Selkirk, as sometimes people from outside the area are like, what is Selkirk Neurology? This is the main mountain range in the region. Here you can see this is Sullivan Lake, where there's an airstrip for people fly in here because it's hard to get to. It's the theme of one of the themes of this presentation. But it's a beautiful lake in the mountains of northeastern Washington. Hobbyists that love to fly will fly in there and camp. This is Priest Lake with Selkirk Mountains kind of on the other side of that here. Go ahead and hit next. And yeah, okay. This is not the Selkirk Mountains. This is Glacier National Park, about 4 hours away. And this is an area where patients have to drive kind of past or around sometimes to get to the medical clinic. So just wanted to leave you all with some visuals as to some of the potential barriers that are related to elevation. And next. Go ahead and hit next again. There's a little animation here. This is an imagined I-90 during potential morning trip to HD clinic at Selkirk Neurology. So this is the Interstate 90, which runs all the way from Seattle. And from Seattle to Minneapolis, Spokane's the biggest city in between the two areas on that major thoroughfare. And this is the pass, Lookout Pass during a snowstorm, which is frequent during the winter. Okay. And just another visual of what it looks like if you're on the inside of the car trying to drive through that. Okay, next we've got a couple of kind of moving points here. So first of all, raise your hand if you get care or provide care at an HDSA COE. If you get care or provide care. Nurses in the back, provide care, or our partner site. Okay, good. Keep your hands raised if you or your patients drive at least 100 miles to get to clinic. At least 100 miles, not all of them, but any of them, if right? Yeah. So this is a common thing. And then next, if so, then you may be affected by rural healthcare issues in Huntington's disease. All right, so some objectives. We can go ahead and just kind of flip through these at the command center. Understand access issues that may be frequent but not exclusive in rural areas. I mean, the things that I'm speaking about here, I feel like we maybe have to encounter more frequently, possibly, and more consistently than some of the big COEs and larger cities. But I think everyone really, to some degree, has to be aware of this. And frankly, there are barriers to care even in urban environments that are not necessarily related to population density and things like this. Explore unique challenges for receiving and providing care for HD in this setting, and prepare to use solutions for barriers to care in your local region to improve outcomes for HD. A lot of the things I'm going to be speaking about are, there's quite a bit of telemedicine and telehealth. Oh, new clicker to the rescue here. Things that most of you have heard before, but I hope to present them in a little bit more of an analytical view and talk a bit about strategies a bit more explicitly to make this more relevant for everyone. So for a long time in the United States, rural health care and access issues have been well recognized, so much so that the Health Resources and Services Administration has now online resources, the Rural Health Information Hub. And they have a problem statement. The first is the blue box is theirs and the yellow box is mine. The blue box is that health outcomes in rural areas are worse than in urban areas. Solution statement: access to current and reliable resources and tools help you learn about rural health needs and work to address them. And I think the key for this is the latter part, the work to address them. I mean, these are all great ideas, but the work involved is tremendous and requires a lot of collaboration and is costly to do this work. And so therein, kind of remain the challenges that keep this in the area of the ideal but not yet possible for so many patients. And this stuff matters. I mean, I see the results frequently of a lack of access to care, and it's bad. Dr. Bird was speaking, yesterday evening about some of the problems, with still getting care and how far we are from where we need to be. And I think that this model is really key for so many things in medical care, and particularly with HD. It's such a complex disorder. It's a very good case study to consider. So in our situation, we want to be aware that outcomes for people with HD may be worse in rural or regional areas where there's less access to care. And the solution statement is to better understand HD specific health needs in these areas and work to address them. So these are some general statements, all from the Rural Health Information Hub. And just to state it more plainly, the access to healthcare is important for the physical, social, mental health status. A big thing is disease prevention, or I would add disease complications in the case of Huntington's disease, where we can't yet prevent Huntington's. But certainly we see complications of things that can be missed, whether it's compliance with medication and consequences of that, lack of clarity of what people are actually being treated for with HD. Concurrent illnesses that may be attributed to Huntington's disease that are not, cancer or other GI issues or other types of problems that may be inappropriately written off as Huntington's related, because healthcare providers do realize Huntington's is complex and just say, well, that could be HD. So those things I think are just a lot of low-hanging fruit out there that we're not getting at right now, and it's so important. Improving quality of life, and a big thing, avoiding preventable deaths and life expectancy. Improving life expectancy is so long as it should be, and people will benefit from that. And a couple of one kind of big point is, again, so much of this work and what we're discussing, it seems so obvious, but to state it explicitly, I think is something that must be done frequently to follow through on what we know needs to be done. So people living in rural areas often have barriers in access, and healthcare has to be attainable, so they somehow have to get it. And the other thing is that it could be obtainable. This is the big problem in medicine. Well, it's there. We made the referral. Oh, we just got to schedule them. Oh, the scheduler didn't call back. Oh, we can't get a hold of them. It's it's the death by 1,000 cuts, or the complications of HD by 1,000 cuts, because many people with HD and their family members have a lot going on. They're burdened by the complex nature of the disorder, and so facilitating these things are incredibly complicated, and following up on calls to have things scheduled, letting people know that there's a big urgency if there's a psychological crisis with HD, psychosis, things like that. I mean, it has to be timely, and we all suffer from this, but I think the consequences can be a lot greater with HD than many other disorders because of its nature. So even if health services are available, there can be other and timely, so let's assume the first two conditions are met. Well, there can be lack of financial means. As a neurologist treating neurodegenerative disorders like Parkinson's, so many of my patients are older. Our doctors and neurologists that are MS doctors, they deal with a lot of younger people. Well, HD is a very unique neurodegenerative disorder where there's a lot of younger people, and until we get improvement in legislation to get disability or more timely Medicare access and things like that for HD, they may go without insurance. They may lack financial means. And in our clinic, for example, at Silkirk Neurology, we're a private practice, and the thing with this is flexibility. We actually have the ability to see patients for free. Many big centers, they still have the bureaucracy of the whole corporate systems, and they can't waive that. We can just waive the payment, just see them. A lot of places can't do that for patients that lack financial means, and that's a big barrier. And even if they have some way of doing that, they have to apply for assistance. Transportation's huge, and so this I think the connection that is made for people with HD is often best made in person, at least for the first visit or periodically. And getting someone to clinic who has mobility issues, problems, or concerns about being in public socially with their symptoms, and may have a working spouse or a care partner, it can be incredibly difficult to physically get them to clinic. And these are things that we don't experience in movement disorders neurology for so many other conditions that are quite unique. Confidence in their ability to communicate with healthcare providers. Again, back to the complexity of Huntington's disease. There's lots of nuances here that can be difficult, and if in the rural area that's not well communicated, we'll talk about this when we'll cover a primary care section. That can be challenging. In Central Washington, we have a large Latino population, and many of those patients are not fluent in English, and some may have limited health literacy, even whether they're a non-white or racial minority group, or even areas where they're and lower health literacy out in the rural areas. So that's something to keep in mind, and we always want to make sure that information that we're delivering is received in a way that's culturally appropriate, that makes sense, and that is valuable for the patient, and that they understand, and they leave the visit knowing more than they came in with. And that I think can be harder for people from rural areas. I think there can be health literacy issues that we see more often, at least, than those in urban areas. And then the confidence that the place they're going to is going to provide quality of care. And again, we'll get to a primary care section where I talk about some things here I think may be a little bit uniquely for this group, which is so used to hearing about the importance of specialists in Huntington's disease. So more data from the RHI. A lack of healthcare access affects health. The PCP may be far away. Actually, their primary care doctor can be far from the patient, not just the specialist. Often the PCP substitutes for specialists in rural areas, and then the patient may have a good relationship and forego specialty care. And that's a double-edged sword. It's very important, no matter what a patient's living with, to have a strong relationship with their primary care doctor. And one of the things I've tried to get away from as I've become more, kind of my mid-career movement disorders neurologist, I've tried to not be all things to my patients as much as I perhaps was earlier in my career, and really try to encourage them to establish good primary care roles and relationships, because I think that's very important, and particularly for Huntington's disease, there's so much here work that needs to be done, and having the primary care involved with that and becoming more educated over time is huge. We actually probably need more primary care education as much as we can kind of connect with those guys, and not to kind of draw lines around that and to pull it all into the specialty areas. Medicaid, many of our HD patients are on Medicaid, and the Medicaid access can be pretty low for patients in rural areas compared to urban areas. And actually, some people, this is a surprising thing. We have a lot of, well, Californians move everywhere, as we say. So if you're from California, you know how this goes. You've heard this trope before. And so a lot of Californians move to Eastern Washington, Northern Idaho, a lot of land, et cetera. And we'll have patients move here and say, there are no doctors. Like I've retired well, saved well. I've got this beautiful, and I'm an hour and a half from doctors, and I can't even get into what's going on here. Like, well, you moved to Northern Idaho. What did you think was going to happen? So it's not all about health literacy, education, like wealth. Some of it's just simple geography, and people do find themselves in these circumstances, which is really very interesting. And being here in the inland Northwest region, I get to see this, and it can be a challenge. Go over quickly, just kind of a map visually showing you what is determined to be a metro versus non-metro area. Not advanced. Okay, there we go. Visual review. Thank you. Please keep that up. Be vigilant. So again, here I'm pointing to this blue area in the eastern part of the state. This is actually this is part of our region. This is considered a metro area because Spokane's here. But I can tell you, this northern area, Pierce, Stevens County, and some of these other areas are pretty hard to access. And then these other large swaths of land in the non-metro areas are pretty even harder to access. Okay, go ahead next. Okay, this is Idaho. You can see Idaho is almost the entire north part of Kootenai County here, which is Coeur d'Alene. That little blue area is considered a non-metro area, and that's over a quarter of the population of Idaho lives in non-metro area. And most of those blue areas, by the way, are mountains. So between Spokane to central Montana is the largest wilderness area in the United States. This is a massive area of mountains and rivers, streams, and very hard to kind of get through, and except in ideal circumstances on the few roads that are there. Okay, next. Okay. This is Montana, which is mostly non-metro. Areas are Missoula and Billings here have a little more coverage, but the entire state, of 1 million people is scattered out there, and largely in areas that many of which can be hard to reach. Okay, I think I'm working again. Oregon, not to forget Oregon to the south. The northeastern Oregon here, we don't have as many patients from here. It's a less populated state than Washington, and the concentrations are very, very much on the I-5 corridor. But there are a number of patients who will come from this area, and you can just see that the eastern Oregon area, which is fairly sparsely populated, but does have a sizable contingent of non-metro dwelling patients. Okay, good. All right. So, so what is it we're trying to do? What are we trying to deliver? Well, the standard of care for Huntington's disease is considered, at this time, comprehensive multidisciplinary care to manage symptoms that we can with medications, and otherwise do whatever we can to maximize function and maintain quality of life. The COEs, the Center of Excellence sites, which we are a Center of Excellence partner site through University of Washington, so we receive some support from HGSA for some of the Huntington's work we do. And we adhere to those standards, aspire to adhere to those standards, and it's kind of meant to be kind of a one-stop shop, getting care ideally for many patients on the same day with social worker, psychologist, neurologist, and what have you. Centers do that to varying degrees, which we'll see. So this is actually, I think we heard yesterday evening that they're up to 60-something COE and partner sites, I believe. But this publication in 2020 looked up to 2017, and there were only 41 specialty centers across the area, and they weren't equally distributed from a geospatial perspective. Here's some numbers here. Let me break this down for you here. So this is how close people are that receive Medicare benefits. How close they are, people with Huntington's that have Medicare benefits to HD COEs. Okay? So here in green, this is kind of the ideal situation. This shows that these are people with Medicare benefits that have Huntington's disease. That we're seen at a COE, and it's about half, which is pretty good. I mean, that certainly could be worse than that, but it kind of breaks down to about 50% of all age groups. A little bit of race and ethnic disparities that are probably more related to kind of how people choose to live in the U.S. But There are a lot of people getting care from COEs, but a lot of people not, and at least in a way that's considered close, or what is considered by this article to be accessible. And it goes further to break it down from 100 to 250 miles, and about a third, maybe-ish, about a third of people get care have about 100 to 250 mile drive, which is far. I mean that is a length that I can tell you as a doctor that sees a lot of people, more than a third, I would say, with HD from this. This distance, it makes frequent follow-up when needed challenging. It really does. I mean, it can happen, but it's tough. And then beyond that, it is even worse. And I think we have a little bit more even beyond that. And some, a small portion, very, very, very far away. Okay, so this is a map from this article, Journal of Huntington's Disease, looking at geographic variations of Medicare beneficiaries with Huntington's living in close proximity, less than 100 miles. This is the green box. To HD-COE in 2017. And you can see certain areas are doing pretty well. The Northeast is doing pretty well. California is doing pretty well. Some areas in the Southeast not so bad. And this whole middle part of the country, which I think we're kind of at the edge of here, really not quite as good for access as would be needed for patients. So that's the problem. And I think that visualizing this is very important. When certainly HGSA is aware of this when they considered us as a partner site, and I think probably many other ones as well. And we'll talk about some of the unique challenges with insights and variations. But just to have some dot on the map where there's some point of entry, I think that's the key thing. That's a starting point when we're talking about solutions moving forward here. And this is our referral area. So we're, comfortably kind of right in this area of need based on the 2017 map. I think this would look different now. I'd be curious to see, a 5-year follow-up or maybe a 10-year follow-up and see how things might change over time. But this is what it looks like until very recently. And this is just a zoom in on this region that I'm talking about. And most of you are from other areas, and our online attendees, of course, are all throughout the country or greater. But this is sort of this is sort of what an rural or a regional underserved area kind of looks like, compared to an area that's a little larger. And these are groups with any affiliation whatsoever, even very, very superficial with HGSA. So trying to get something on the map. Okay, assessing the state of care for HD in the United States, looking at results of a survey from centers treating Huntington's patients. This is Lauren Seeberger's work, and actually I was surveyed by Dr. Seeberger, who was out of Boise and then is out of Colorado, I think, at this time, for the HD Net project, which is something that the Huntington Study Group has kind of undertaken to study access to care and how is careless care delivered in the United States. And that's sort of what a lot of this project is focused on. And what they're looking at, historically, a lot of the demographics and data collection in Huntington's has been so driven by great studies like Enroll HD, which are phenomenal and have given us wealth of information about Huntington's. It's a big registry study that's been running for many years now. But this group was looking at medical care for all HD patients in the United States, and not only those at Enroll HD sites. And so it's the largest clinical survey ever of HD in the U.S. And basically what they found is that just over a third of patients practices for HD, so seeing HD patients saw more than 50 a year, and about a quarter saw more than 100 a year. These are largely going to be your really busy university programs, very, very high volume programs. But 50% of practices saw less than 25 patients HD annually, and so this is a lot of people. A third of these practices were academic, and greater than 10 were VA-based. So there's still a good portion of people with HD getting care through services like the VA, and that might be the only one. What this group's comment was, one of the takeaways from this is that HD care is inconsistent across the United States. It seemed that better equipped multidisciplinary staffing occurred if there was a movement disorders neurologist available and involved, and they had higher volumes. And that somewhat follows and makes sense. But even at many of the COEs, there were no preclinical assessments, preclinical visits performed with the patient from home to kind of prepare for the visit and organize and coordinate it. And half the practices lack dietitians, genetic counselors, psychologists, psychiatrists, care coordinators, rehab allied health therapists, even within their systems. So uniformity for HD care, it varies widely. Dietitian and care coordinators were the least likely to be part of these clinics. And then wanted to turn towards primary health care. This is a study from Norway, which has very different medical system than we do, more of a kind of communal system. In Norway, it seems primary care clinics in rural areas are more involved with HD care, and understanding and experience of the primary care group is very important to understand how healthcare occurs in rural areas. And so they kind of took their system as it was and kind of analyzed this specific area of care delivery. And so for many people living with HD and the family, the primary care clinic is the main source, and specialty care is considered the gold standard. But the role of primary care, it really can't be overlooked. And in fact, sometimes, again, this thought occurs to me more and more as the longer I practice, is sometimes there can be a bit of a trade-off. The more there is engagement with the specialty care clinic, it really can remove some of the relevancy and role of primary care. And I think we have to thread the needle very carefully on that. The PCP relationship with HD has many advantages. They may know the patient and the family well, particularly even more so in areas where that's the only place to go. And in urban areas, this is a very big difference, right? I mean, your mom or dad may say, go to this clinic where I go. You may say, I'm not going to go where my mom or dad goes to see their doctor. It's like the last thing. But this actually happens a lot in rural areas. It's very, very common. When I get referrals from rural areas in Montana, North Idaho, a lot of times the primary care, they've known about HD and their family members, and they know this and that. They tell you, it's incredible the amount of information that they'll know about these patients, and even sometimes on a handful of occasions what kind of medications worked well for family members versus others. And that's just stuff that you can't always replace by just taking a history and doing a physical and reading it in a book. Relying on PCP, though, as the main care provider for HD has many disadvantages. They do have a lack of specialty training, and there can be kind of a consolidation of these specialty services far away from the primary care setting, again, kind of putting things in silos. And then the other thing is that primary care providers are often under very, very short time constraints, and this is a major and this is a problem. Really primary care should be available to coordinate complex care issues, but often in our society, the way that the economic model of medicine is driven is that's the last thing they're able to do, even though they're paradoxically maybe well positioned to do so. So I think it's a real important conversation to continue to have and to recognize. This stuff is obvious to all of us, but saying it explicitly, putting it in form that can be analyzed is very important as we want to propose changes to how care delivery might occur. So in this study, it was a survey. It was a very qualitative survey, very kind of, just what do you think? And there was some general form to it. But they looked for barriers. So what was it in this Norwegian primary care kind of model in their clinics that they found were barriers for HD care, and reasons primary care groups and providers, thought that they maybe weren't comfortable with it? Well, aggression, and with HD as it advances in the behavioral features, the aggression, irritability, mood instability can be a major problem for everyone. Problems communicating, the motor speech disorder. With Huntington's disease, one of the things that I try to explain to providers is that the cognitive impairments in dementia and Huntington's is very different than Alzheimer's disease, which is an amnestic disorder of memory. Whereas with HD, it's different. It's a condition where certainly memory can be affected, but a lot of times if speed of communication is the thing, and you have to just give people time to communicate the issues. And that's very, very important. And of course, talking about how the limited time that can happen, maybe not in the Norwegian system, but certainly in the US system. And then unique psychological and emotional challenges, interaction with other family members, particularly due to the nature of the disorder, which is transmitted throughout families. The primary care, they cited professional competency, not feeling capable, not feeling confident in providing care for these complex patients, and perhaps they should get more specialized care, and therefore they didn't want to participate as much. And then support for the healthcare system. So maybe their health system in the primary care model wasn't really set up to support them as much. And also coordinate care, and we'll talk about that here in a minute. All right. Quality of care for HD in the United States, and this is a survey. This is an online, Michael J. Fox Foundation for Parkinson's did something like this years ago, and they surveyed like 10,000 people. So this kind of reminds me a lot of that. So it's very kind of open, very, not what you would consider necessarily kind of or scientifically kind of precise, but good for just data collection, we like to say, in research, or generating a hypothesis. And so these were patients that responded, the ones that responded to the questions in the survey about the current level of care. And of the ones that responded, 41% said that they were receiving medical care, which is interesting, by a physician or a health provider of some sort. Others that they were getting community care, which included physical therapy, home safety assessments, some housekeeping, Meals on Wheels, some assistance with budget and finding community resources. And a good chunk were receiving both, which is kind of neat. That's 30%. That's a lot of people with HD. About a third, they were kind of getting a nice combination. Concerning though is that nearly a quarter reported receiving no care at all. And these were, by the way, let me clarify, these are people with HD or at risk, or family members or caregivers speaking about their person in their life with HD. So these were concerns that were brought up here. Reasons for no care. And I kind of highlighted three here. I don't have access to quality care. I live too far from a place providing the type of care I need, and high cost of care. And those are very concerning things because they don't really have much to do with things that are not solvable. I mean, costs of care with medical insurance can be addressed, or with grant programs, things like that, potentially. Living too far from a place providing this type of care, we're going to talk for the remainder of this presentation about how to bridge the gap. And then inherent in that is access to quality care. And so again, quality care, I think for HD should be all care. I think all care should be quality, and quality care should not be synonymous with specialty care. It should be all care. All care that they get for this complex disorder should be high quality. So working to address the needs of HD patients in rural settings. So what do we do? We're on the solution side of it, other side of the mountain, so to speak. The target population, kind of we're talking about here, is this 50% of people living more than 100 miles from a center of excellence or partner site, and that they'll need to have increased reliance on these strategies in order to live their best lives. So this is kind of a breakdown on a couple of items here. A lot of, we're speaking a bit about telemedicine, some educational programs via online access, community support groups assisted with technology, enhanced medical professional communication, transportation services through grants and local medical transport agencies, and local health worker training in collaboration with specialists. Again, none of this is like sexy, fancy research stuff, that's going to cure Huntington's, and which we need all those things, by the way. But this is boots on the ground, like work that needs to be done. This is trench work. It's the grind of initiatives that I think could really make massive amounts of difference to people living with HD. And while we're all waiting for cures and things to really slow progression down, this is important for the here and now. And so COVID-19, my goodness, trying to find silver linings in COVID-19 has been sort of our quest in the last few years. And COVID-19 and telemedicine certainly has been a big one. Again, I was involved with telemedicine research years before the onset of COVID, and we had a fledgling telemedicine program, so we were poised, we were ready to go. When COVID hit, we just kind of pounced on this telemedicine thing, and I've as excited as I was before COVID, I'm sort of like, oh my gosh, another telemedicine visit, now. So prior to COVID, let's just kind of state what's changed in the last couple of years. And this is very, very, very relevant. This is very new stuff. Okay, this really, and we're kind of used to it a bit, but this is a big deal, and I don't think we've all quite had the time yet, or these organizations like HGSA even, to process how these changes with access to care and technology have occurred, that really we can formally kind of use and get some big improvements in care. So before COVID, quickly, doctors had to be licensed in states where people resided to provide care. There was no payment for this stuff. This stuff was cash pay. Okay, when I did it, it was convenient. It was people that could afford it. It was cash pay mostly, and there was no frequently used system. There was no like established way to do this. If we were doing it, we were always kind of wondering, gosh, is this HIPAA compliant or not? It seems like it is. Maybe it's not. Let's just not ask. So, and then during COVID, right, when we went from excessive regulation to COVID, there was no law, right? There were no regulations whatsoever. It was whatever, to get care, just do whatever you can. Medicare was paying for everything, it was like, sure, we'll pay for it, and we'll give you bonuses for this and that, and just stay open. Licensing requirements for all states were suspended. Insurances mandated to pay for most services, and you could use whatever, FaceTime, Zoom, your EHR platforms, which were many of them yet to be built. Now that things have kind of settled down after the pandemic, we do now require to be licensed in certain states where care is delivered to, for the patients at. But many more physicians nowadays are enthusiastic, and many more patients nowadays are enthusiastic about telehealth as an option. I mean, we're just like recovering from this, but I think this needs to be said, and this kind of new normal can be used in part of the flexible nature of care for HD moving forward. Insurances now, the vast majority of insurances pay for telehealth, and that was probably the biggest change, and that's unlikely to go away in my opinion. And then more doctors and patients are comfortable with technology, the software. It's not perfect. We won't go into the details of that today, but that has changed. And then just to go over quickly, teleconsultation. This is the telemedicine visit. Raise your hand here if you've ever personally experienced a telemedicine visit for anything, ever. Yeah, so like that's everyone prior to COVID who had experienced that. Yeah, I mean, right. So this is a massive, massive change. And these are some other kind of interesting things that I'm not going to dwell on a lot, but I just want to speak about telemonitoring. These are using sensors and like mobility monitors, things like that, which they're in the very beginning, fledgling nature of these monitors for mobility and falls and mood monitoring. I mean, all kinds of stuff. We're going to be getting more useful data down the road, and it'll be done remotely from the patient's home. Psychiatrists, and radiologists have been at the forefront of telehealth long before the pandemic, and it really has even further picked up. But I struggle so many times trying to find quality behavioral health care for my patients with HD, and trying to one of my hopes is an organization like HGSA will further efforts to kind of consolidate, streamline practitioners that are in regions for this that have interest and expertise in HD. I think that will really help, and something that we'll see more and more. Okay. Telepharmacy, I won't kind of go into that, but that's having and engaging with pharmacists to have the most appropriate, lowest cost, and fewest drug interactions with medications as possible. We could have more, some of these large universities have pharmacists on rounds, but most of us don't have things like that, and that would be fantastic. And then home care, mini mobile health. This is like imagine an HD van pulls up, and has like all your services for half a day, and and you get your services done that way in reverse. Well, believe it or not, those things have now started to happen for stroke care in the United States, mobile stroke units. And I think that, man, the future, it just depends on how creative we are and how motivated, and trying to bring low cost, high quality care to people with chronic conditions that are isolated. It's not something that cannot be done. We just have to keep working at it. And then telemedicine can be available, but again, not easy to use. Who here has ever tried to do a telemedicine visit where the signal was disrupted? Right, so we have the technology, but it's not perfect. It breaks. Having internet access does not mean that you have a device capable of telemedicine, even for that You can't have a device that's too old. It may have to have software installed. Having a device capable doesn't ensure that the person on the other end that their voice can be heard. Their voice may be impaired from dysarthria. They may have dementia or cognitive issues and may be distracted. I mean, I've had a patient, I'll tell you, there's nothing more vertiginous for a doctor than having a person with Huntington's disease with chorea in a Walmart parking lot in northern Idaho holding their cell phone with chorea. And I've done visits, more than one, visits like this. And I'm like, and I have to point out, I'm like, your chorea is really bad. Can you put the phone somewhere? They're like, well, then I'll be moving too much and the phone won't track me. And so they've thought about this. Their patient on their end is trying to come up with solutions as well. So there's a lot of things for the idealized nature of telehealth that we hear about and the slickness of this whole product. I mean, it's deceptively still challenging to use, and we should not assume and settle that, telehealth is there, it's available, it'll fix everything. There's a lot of problems. There are some solutions, though, for things like this. Private rooms in the public libraries. Our public libraries are massive resources. They're like the gold mine of our counties and kind of government systems. Our public libraries for so many things, information access, but also internet access. Very important. Walmart, God bless them, have some mixed feelings in some ways, but they have great internet connection from their parking lot. I've done many visits from Walmart parking lots, many actually, with patients on their phones, some with chorea. And then also I've had PCPs reach out to me and say, hey, they said they had a hard time getting a hold of you with the visit, or the visit dropped. Can we do the visit in my office? I've had that happen one or two times. I want to speak a little bit quickly about chronic care management, then I'll kind of move on through the end in the interest of time. But chronic care management is a service that we've been doing at Selkirk Neurology for a while. This is a monthly call from a nurse to the patient, where they check in on the patient and see how they're doing. They call once a month. The service is paid for by Medicare. It's a relatively new service. And patients love it. We have a nurse coordinator who calls them once a month, and not every patient qualifies, but if they have chronic conditions with Medicare, and many private insurances will cover it. And they get a personalized care plan every 6 months. Selkirk Neurology in 2023, we conducted over 1,100 visits, chronic care management. And actually this stuff, it's not, as your doctor, it's not the most lucrative thing to do, but it does cover the salary of your nurse. And for patients, there can be a small copay associated with it on the order of less than $10 usually. And they often feel it's very valuable. And it can be a critical link for people that oftentimes are not able to come into clinic frequently, that have active issues, chronic issues, and this is something that I think something like 5% of clinics in the United States are using this service. So it is something that's very underutilized, and there are some limitations in use of it, like with Medicare, but something I really wanted to get to and plug. We talked a little bit about telemedicine and movement disorders neurology. We won't go into that. Some of this is obvious with the weather and whatnot, but flipping visits from regular visits to telemedicine visits, those should be something that every clinic should be able to do the day of the visit. I'm not sure if that's people's experience, but that we schedule visits, telemedicine or a regular visit, a regular clinic visit. If it's a regular visit and they can't make it, it's immediately switched to telemedicine. Our staff are trained to do that, and that there's no reason that a medical system shouldn't be able to support that type of need for a patient. Social work, we're trying to continue to engage our social worker in the telemedicine process. Getting a licensing in different states is something that's important for that. And to the critical services of social workers can be best applied if they're connecting with the patient frequently and as the patient needs it. Coordinating care with the rest of the movement disorders team. There's HGSA online group descriptions. I'm going to skip over that. I'll summarize this quickly here, the enhanced medical professional communication. So doctors communicating and health professionals communicating about medical care in HD is really, really, really important. Nowadays, fortunately, getting notes to other providers is really easy. I'm in a private practice. We have a standalone EHR system. It's reasonably affordable. It's not the most fancy thing in the world. It's a really nice system, though. I like it. And I can read everyone's notes. Most doctors' notes. I can read care that occurs at University of Washington, at OHSU, at Mayo Clinic, anywhere in the country, at small community hospitals in Idaho and Montana. I can read all of these because of this common clinical data set that was instituted about 5 to 10 years ago. Basically, more and more physicians, majority of them have the ability to do this nowadays. So you should expect now more than ever that your doctors can read notes and care can be kind of coordinated. We're going to skip transportation services. This is a good way to summarize local health worker training. I've just got one or two more slides left. Selkirk Neurology, we do a lot of teaching. I teach medical students all the time. We now have every month a PM&R physical medicine rehab resident, and also we take psychiatry residents a few months out of the year, so we do a ton of resident teaching. We teach PA nurse practitioners, physical therapists, and so getting care at a place where they're doing teaching, that's actually very important. And if you are living with HD or a care partner, certainly take time to explain what HD is to other people that are there to learn. That's incredibly valuable. Unless there may be a nature of the visit that could be very sensitive, or you don't want to do that, of course. But otherwise, consider that actually a really opportunity to reach out, evangelize a little bit. So this kind of comes to the end of my slide. I'll have a summary section here and then take one or two questions if we can. So access to healthcare is a frequent challenge in the medical system. HD is a complex disorder, and so we have to work a little bit harder, basically. And even going to a COE, it can be hard to access all the resources there if you can't get it frequently enough. And a creative solution have to come from the clinic, but don't just rely passively if you're an HD patient or a care partner. Don't rely passively on the clinic to provide all these things for you. Know about these things, ask for them, advocate for them, and kind of reach out for finding them in your area. All right. Yeah, if you have a couple, I'm happy to answer questions.
David Scholl, Anchorage, Alaska. Very interesting. Thank you for this presentation. I've been told by doctors that we will not get care because we live in Alaska. Bottom line. I've tried to get telehealth, they won't do it.
So Dave's from, and I'm repeating it for the online attendees. Dave's from Alaska and has been told he can't get care because he's in Alaska. He's here at the meeting, and kind of a comment and kind of a general open question, maybe like, what should I do?
Because my son doesn't get care from the VA, we have to fly to Seattle.
Yeah. Well, so, I know my colleagues at the UW, which is a Center of Excellence for HD. I know that they do telemedicine there, so that's certainly something to reach out for. I have licenses in Washington, Washington, Idaho, Montana, and Arizona, but not in Alaska, but if there was a need, I suppose. But no, I wouldn't settle for that. Long story short, anytime you're told you can't get care, just don't settle. That's the short answer. That's the short answer. Just don't settle and reach out to the HDSA, present them with this problem. That's exactly why this organization is here, to advocate for you. All right, very good. Yeah, and I'll be around if you have any questions after. I can take them any personally, and sorry for running a bit over. All right, thank you.